Today we will be talking about antimicrobial stewardship in pediatrics. And over the last few days, we heard about a lot of antimicrobial stewardship in different settings: OP settings, IP settings, and ICU settings. And today I am planning to talk about antimicrobial stewardship only in common pediatric infection. I will not be covering the critically ill child and hospital acquired infection. I will only be touching upon the how to select antibiotic for common pediatric infections. As we were hearing, antimicrobial stewardship is actually nothing but prescribing antibiotics only when indicated, and whenever we are prescribing, we make sure that antibiotics are prescribed for diagnosis, and we are giving the right drug in the right dose, and we are starting the antibiotics in the right time, and will be continuing for the right duration. That is the antibiotic stewardship. And it is otherwise known as responsible use of antibiotic. That does not mean that you don't use antibiotic in the indicated cases. It means that you give antibiotics whenever indicated, but at the same time, you make sure that there is no overuse. So that is the responsible use of antibiotic. Why is the antimicrobial stewardship important? Why? Because the antimicrobials are societal drugs. That tells us that whenever you're giving antibiotic to a patient, it produces effects not only on the treated individual, it produces some effects in the community also. Whenever you are giving an antibiotic to a person, as we said earlier, there is a chance of developing antimicrobial resistance. Those organisms which are there in the patient will develop antimicrobial resistance. And the funny thing is that the microbes or bacteria are not at all selfish in regard to this development of resistance, and they will share their genes very freely so that all the organisms, a lot of different organisms in the patient will become resistant to these antimicrobials, and this will be transmitted to the community. So even if an individual as such is not exposed to an antibiotic, he may harbor a resistant organism. And whenever the patient is treated with antimicrobials, this will also lead to some changes in the gut microbiota. There may be intestinal microbial dysbiosis, which can lead on to later non-infectious diseases or non-communicable diseases, such as inflammatory diseases and asthma. And as we said, whenever an antibiotic is introduced into the community, they will actually have a very good effect. All the all the microbes in the spectrum of activity will be resistant, will be sensitive initially, but over time, these microbes can occur resistance, and the efficacy of the antimicrobials will vary over time. So whenever there is an increase in the antimicrobial use, the antimicrobial resistance will also proportionately increase. If we are able to use the antimicrobials wisely and judiciously, we can decrease this rate of increase in antimicrobial resistance. So as we said earlier, this is nothing but using antimicrobials responsibly by balancing the patient's needs and society's needs. Patient's needs is to get cured of the infection, and society's needs is to actually decrease the incidence of antimicrobial resistance. So what is the importance of antimicrobial stewardship program in pediatrics? Because infections are very common in young children when compared to all other age group. And also in these young children, most of these infections are viral infection. At the same time, some of them may be having a serious bacterial infection for which an antibiotic is really indicated. The problem is that it will be difficult to differentiate between a viral infection and a bacterial infection in children than in adults. So this will lead on to overprescription of antibiotics. Whenever a child is ill, the parents will be anxious. Whenever our child is ill, we will be anxious. Same like that really. Whenever a child is brought to us with an infection, they will be parents will be anxious, and not only the parents, even the physician will be anxious, because whenever we are seeing a small kid with fever, the most important concern for us is that we should not miss any serious treatable bacterial infection, so that even the physician will also be anxious, which will actually result in overprescription of antibiotic. Another thing is that in order to reach an adequate diagnosis to differentiate between the bacterial and viral infection, it will take some time. The physician has to take a detailed history, do the clinical examination, some days may even have to do the relevant investigations and reach at a diagnosis. And if at all the physician thinks that this is a viral infection only, then also the physician has to actually talk with the parents, and we need to actually convince the parents that this is only a viral infection and antibiotics are not needed now at the present time, because most of our parents actually they all actually demands antibiotics for the patient, for their children. So all these things will lead on to overprescription of antibiotics, and antibiotics are the most common, one of the most commonly prescribed class of drugs in pediatrics. So what we can do, the most important thing that we have to do is that to make ourselves believe first that antibiotics are not antibiotics. We need to teach our students and our patients and parents also the same message. And there is no need for prescription of an antibiotic just because the child is having fever. So what will the doctor do? Whenever we see a patient with a fever, the most important thing for us to do is that we need to have a clinical diagnosis. As Dr. Aravind was saying, there is no, what we have is we need to have a syndromic diagnosis. So what is the source of infection? Why is this child having fever? So what is the source of infection? That is what the first thing that we need to know. And once we identify the clinical syndrome, we need to know which are the organisms which is responsible for this clinical syndrome, whether it is likely to be bacterial or viral. And also what is the antibiotic indicated for that clinical syndrome. And we also need to know something about the patient characteristics and also the likelihood of our patient harboring a drug-resistant organism. And once we decide that our child needs antibiotic, we need to try to prescribe the narrower spectrum antibiotic for that person. Unless the patient is critically ill or immunocompromised, we need to prescribe the narrower spectrum antibiotic for that person. And also at the same time, we need to prescribe an antibiotic which has least resistance potential, the chance of developing resistance. That is our ideal aim. And this usually we can actually do this by following the local guidelines. There are a lot of guidelines for almost all types of bacterial infections in children. So following the local guidelines, we are actually ensuring that we are prescribing the narrower spectrum antibiotic for that infection. And whenever we are prescribing an antibiotic, we need to prescribe the drug at the right dose and also has to be given for right duration. And whenever we decide whether the patient is requiring an antibiotic or not, even if we are sending the patient home on antibiotic or without antibiotic, always talk to the parents. Tell them when to bring back the child. Suppose the child is not improving, child is becoming sicker, they have to bring back the child. A lot of problems happens when the person, when in the beginning, maybe a patient may be seen by a doctor and may have been given some drug, but even if the baby is worsening, they may not actually bring back the child. They will continue to give the same drug and keep at home. So we need to actually tell them when to bring back the child also, because small kids are actually not going to comprehend. So the parents should be actually empowered to identify when the child is not improving and when the child is becoming sicker. So these are the principles of optimal antimicrobial use. When the physician first sees the patient, we will make a clinical diagnosis. we will we will do diagnostic workup as and when indicated and will reach at a therapeutic decision, which should be followed by a patient or parent education depending upon the age of the child. And as I said earlier, if we are sending them home, we need to advise them when to bring back the child. And when the when the parent is bringing back the child, we will do a subsequent evaluation where we clinically reassess the patient. And if there is any data or investigation research with them, we need to review them. And we may start an antibiotic, we may modify an antimicrobial according to your examination findings. And when we look at the indications for giving antibiotics in children or in any age group, it can be broadly divided into prophylactic antibiotic treatment, empiric antibiotic treatment, and definitive antibiotic treatment. Prophylactic antibiotic treatment, I am actually not going into the details. It is there are guidelines which prescribe prophylactic antibiotics like tuberculosis prophylaxis, UTA prophylaxis, rheumatic fever, infective enteritis, all those things, we have prophylactic treatment. And what is definitive treatment is when you have a culture result, you give antibiotic accordingly. But in most of the cases, we will not be able to wait for a culture result to start on antibiotic. So here we will start an empiric antibiotic treatment. Then that is the most common type of antibiotic use in children. We will go through a few clinical scenarios and see whether the antibiotics are actually really indicated or not, and what are the indications for starting empiric antibiotic in children. So this is the first child. This is a 4-year-old child who is febrile and has right submandibular swelling. As seen in the picture, we can see that the child is having erythema in the submandibular region. And on examination, the child is also having tenderness and local rise of temperature. Should we start antibiotic? Yes, we have to start antibiotic. Why? Because this is a clinically bacterial infection. And this is another scenario. This is a 2-year-old child who is toxic and has high fever for 2 days. And now child is having blood and mucus in stools. So this is also a clinical bacterial infection, acute invasive diarrhea. So this is the first indication for starting empiric antibiotics. Whenever the clinical presentation is suggestive of bacterial infection, you can start antibiotic. Here, there is no need for us to wait, do any investigation and wait for the investigation results or anything. Why? Because these clinical situations are they are suggestive of bacterial infection. So we will decide on starting an antibiotic. And this is another child, 2.5-year-old child with fever, cough 3 days, breathlessness. On examination, child is having febrile, child is having fever, child is sick, tachypneic. There are crepitations on auscultation, and we are making a clinical diagnosis of pneumonia. Here also we need to start on an antibiotic. Why? Because child is on clinical examination, there is a high probability of a bacterial infection. This is another child who is a 6-year-old child with fever of 10 days duration and loss of appetite. He is febrile, sick, and has spotted tongue, and on examination has hepatosplenomegaly. It looks like an enteric fever by our clinical examination. In both these cases, there is a high probability of having a bacterial infection. Here we will start antibiotic, but at the same time, the child may require investigations before starting antibiotics. In the child with suspected enteric fever, we have to send blood culture before we start an antibiotic. And in a child with pneumonia, we can take an X-ray and see before starting antibiotic. And this is another child who is a 2.5-year-old child with fever and crying during maturation, clinically suggestive of urinary tract infection. And microscopy also shows 10 to 25 pus cells per hypography. So this is a child who is having a clinical diagnosis which is corroborated by the investigations to be a bacterial infection. So here also we need to start an antibiotic, but at the same time we need to send a urine culture to get a microbiological diagnosis. And the next child is an 1.5-year-old child with fever, cough, coryza, coryza had the measles-like rash with typical progress. He became febrile on day 7. He had recurrence of fever on day 8 with cough, breathlessness, and crepitations on examination. So this is a child who actually started with a viral infection, but there is a typical progression of the viral infection. So whenever there is something which started as a viral infection is not behaving like a viral infection anymore, we will need to think about secondary bacterial infection, and we will start on antibiotic. So these are the 4 conditions where you have a high probability of bacterial infection. As we said in the first group, which was clinically obvious bacterial infection as in the case of AID or acute lymphadenitis, high probability of bacterial infection as in the case of enteric fever, or even the investigation showing bacterial infection in the case of UTI, and viral infection with a typical progress. In all those conditions, we need to start on antibiotic because there is high probability of bacterial infection in these persons. And this is another baby. This is a neonate with a history of refusal to feed and temporary fever for 1 day. But when we are seeing the patient, the baby is lethargic and limp. Here also, even though we are not sure that this child is having a bacterial infection, we need to start an antibiotic. Why? Because this is a critically ill child. Here you don't have time for waiting. This is a critically ill child. It may be due to bacterial infection, but we need to start on antibiotics as soon as possible in this child. This is another child who is 2.5-year-old boy. On treatment with acute lymphoblastic leukemia. He is having neutropenia and leukopenia. He is complaining with anorexia of 1 day and chory fever. Here also we have to start antibiotics. Why? Because this is an immunocompromised child who is an extraordinarily susceptible to develop serious infections. This is another child who is an 8-year-old boy. He was brought to the casualty late in night with fever of 1 day by his father. And when the doctor is seeing the patient, actually he is febrile, but he is not sick and there is no focus of infection. Should we actually start an antibiotic for this 8-year-old child with 1 day fever? And on examination, there is no focus for us, and the patient is not sick. Usually, we won't start an antibiotic. So here also the patient was sent home on paracetamol. But what happened was the child was brought back the next day morning in shock. So now the mother is telling you that there is hysterosplenectomy 6 months back following RTA. The thing is that whenever we are sending a child home without an antibiotic, or whenever we are seeing a child with fever, we also always need to take a detailed history and make sure that this child is not having any immunocompromised situation. So this is a child who is immunocompromised. That is why the patient rapidly progressed to develop a severe sepsis and septic shock. So in these conditions, we need to start on a presumptive empiric antibiotic treatment. Whenever delay in diagnosis or misdiagnosis is dangerous, as in case of a life-threatening infection and immunocompromised host, even though we are not very sure that this is a bacterial infection, we may start on antibiotics. Here in these conditions where we are starting an empiric antibiotic presumptively, we need to send investigations and start on antibiotic. And once the bacterial infection is suspected, you will start antibiotic after sending bacteria culture and sensitivity samples. So if the infection is proven, then we will step down the antibiotic or continue the appropriate antibiotic if it was an appropriate antibiotic. And if the infection is not proven, we need to actually discontinue the antibiotics also. Because in these conditions, we were starting antibiotics even though we were not very sure that this is a bacterial infection. Just because the child was very sick and also because the child may progress, we were starting antibiotics. So depending upon the results of our investigation, we may have to discontinue antibiotics or we may have to continue antibiotics. So if at all we decide that the child requires an antibiotic, depending based on the previous criteria, Which antibiotic to start is actually an informed choice, which is made by the physician. That depends upon these 5 factors. First one is the severity of the infection and what is the source of the infection, what is this organism producing infection, and what is the chance of our patient having a drug-resistant organism. And some of the patient factors will also decide on our choice of antibiotics, and cultures will definitely decide on our choice of antibiotics. We will see these factors one by one. The first is severity. Whenever a patient is having a critically a severe infection, as in a critically ill child, we need to start on antibiotic as soon as possible. And sepsis guidelines, everything advises that in cases of sepsis, we need to start antibiotics in the first hour itself. First hour is known as golden hour. Within the first hour itself, we need to start on appropriate antibiotics. Second thing is that we need to start on a broader spectrum antibiotic if the patient is having a critically having a severe infection. Why? Because we will not get time for escalation. There is no time for us to start on a narrow spectrum antibiotic and then escalate if needed. That is not possible for a severely ill or critically ill child. So here we have to start on a broader spectrum antibiotic, and which antibiotic will depend upon the source of infection, and also we need to start antibiotics as soon as possible. And the second one is source. This is the one which usually decides which antibiotic that we are going to start, and also if there is a obvious source of infection, such as an abscess, we can actually do the source reduction also. So searching for a source of infection or identifying the clinical syndrome which produces this infection is very important in case of selecting antibiotics. We will see some typical sources of infection. First, we will see the skin and soft tissue infection. This is the this is superficial infection, pyoderma or impetigo. Whenever we see the pyoderma or impetigo, these are the two organisms that produces pyoderma. It could be a streptococcal infection or a staphylococcal infection. Usually, impetigo contagiosa, just like in this patient, is usually produced by streptococcus, and staphylococcus usually produces discrete vesicular impetigo. And as we were hearing for the past 2 or 3 days, the antibiotic of choice for streptococcal and staphylococcal is actually first generation cephalosporin is enough for both these organisms. And cloxicillin can also be given first time, but the thing is that cloxicillin may be difficult to get cloxicillin. It is having a lower bioavailability and it has a very bad taste. So we prefer to give first generation cephalosporin for empyema or for this pyoderma. And sometimes it may be due to community-acquired MRSA also, where we may have to change to clindamycin, cotrimoxazole, or doxycycline. But usually we will start with the patient with the first generation cephalosporin. That is sufficient. And if the patient is not improving, we will have to change to the change to clindamycin or Concerta, considering a community-acquired MRSA infection. And usually sometimes the children may come to us with recurrent pyodermas, but there will be pyodermas which will heal on giving antibiotic, but after stopping antibiotics, they will recur again. This usually happens whenever there is an nasopharyngeal carriage of Staphylococcus aureus. In those conditions, we need to aim at eradicating the Staphylococcus aureus from the nasopharynx, umbilicus, and all. These are the signs where these bacteria are carried. So what we'll do is we will advise them with antibacterial soaps. We can advise them mupirocin ointment for application into the nares and also in the umbilicus. And we also will advise them about the hygienic measures, frequent changing of sheets. All those things has to be done. This nasopharyngeal colonization can occur even in the child or even in the caregiver. So both has to be advised. The same hygienic measures. So by this, we can usually prevent this recurrence of pyoderma. The other soft tissue infections such as folliculitis, furuncles and carbuncles are also usually produced by these two organisms only. And it could be also deeper infections like cellulitis and necrotizing fasciitis can also be produced by these organisms. But in cases of deeper infection, it may be polymicrobial or it may be there may be even gram-negative infections which produces deeper infection, especially if the patient is having some immunocompromised situations. And this is the IDSA classification. I actually don't want to go into the details because this was actually discussed by Dr. Aravind in the previous class. I just want to say that whenever we have a skin and soft tissue infection, depending upon the presence of pus, if it is a pus forming or pus forming lesion, we always think about a Staph aureus producing infection. And if it is a non-purulent, if there is no pus, there is only an infection, then we think about a streptococcal one. And depending upon the severity, if there is no systemic symptoms, it is a mild infection. If there are any systemic symptoms, it is a moderate infection. And in severe infection, there is severe systemic symptoms, which is, or it is not responding to incision and drainage and oral antibiotics, or an infection occurring in immunocompromised is known as severe infection. So depending upon the severity of infection, we can select antibiotic. For purulent infection, as we said earlier, it is a Staph aureus. So for mild infection, we just need to do an incision and drainage, let out pus. Sometimes we need not even have to give antibiotics for that. For a moderate infection, along with IND, we have to give oral antibiotics, and the oral antibiotics, as we discussed, the preferred one is cephalexin or cloxicillin, and if not responding, we will need to change to cover community acquired MRSA, and for severe infections, we need to give IV antibiotics. Suppose it is a non-purulent one as a streptococcal infection. Here for mild also we need to give oral antibiotics because there is no point in doing an IND for that because there is no pus formation. So for a mild infection, we will give oral antibiotics. Here also the first thing is only cephalexin. And severe infections, we need to give higher antibiotic, especially if the patient is having cellulitis or necrotizing fasciitis, you may have to give high antibiotics. Now we will go to the second group of infection, which is the throat infection. In the throat infection also, the most common throat infection is viral. Depending upon the age also, if it is a throat infection occurring in toddler age group, it is usually a viral infection. But we always need to think about streptococcal infection also because this streptococcal infection can lead on to the non-infectious complications like acute rheumatic fever. So we will use these criteria to differentiate between streptococcal infection and viral infection. As I said earlier, in children less than 3 years, that is in the up to the toddler age group, most of the tonsillitis or pharyngitis is actually due to viral infection. In the usual age group of streptococcal infection is the school-going age group. 5 to 15, we usually used to say 5 to 15, but in the center's criteria, they use 3 to 14 years is the time for streptococcal infection. And along with that, what we look for is that if there is high fever, that is also suggestive of streptococcal infection. Absence of viral URI and cough, viral respiratory symptoms. If the patient is having viral upper respiratory symptoms and cough, which is more likely to be a viral infection. If the patient is having tender cervical lymphadenopathy, that is more likely to be having a streptococcal infection. If there is tonsillar erythema, edema, and exudate, it's more likely to be a streptococcal infection. And depending upon all these things, there are scoring system where modified center score is the one which is usually used. And if the score is more than 3, actually that tells us high probability of having a streptococcal infection, and we need to start on antibiotics. We actually don't have readily available rapid and diagnosis test for streptococcal infection. So we will depend upon our clinical judgment. We will look at these factors and decide whether this is streptococcal infection or viral infection. If it is a streptococcal infection, which antibiotics should be used? Streptococci are sensitive to penicillins. So we will give penicillins as the first line antibiotics. The penicillins, either we can give oral penicillins or amoxicillin. Both can be given as whichever is available can be given. And the usual dose of amoxicillin alone is sufficient. There is no need for us to use a high dose of amoxicillin because this streptococcus is very sensitive to amoxicillin. And but the thing is that we need to give antibiotics for 10 days because we want to eradicate the streptococcus from the throat. Another very common infection and an infection where we always prescribe antibiotic is the sinusitis. And whenever there is rhinosinusitis or rhinosinusitis, here also the most common cause for sinusitis in a young child is viral. And we actually need not prescribe any antibiotic for viral sinusitis. This is self-limiting. It will just persist for some few days and will disappear. But at the same time, it may be a bacterial sinusitis. Bacterial sinusitis is usually produced by pneumococcus, H. influenza, or Moraxella catarrhalis. When will you think that this is a bacterial sinusitis? That depends upon these 3 factors. Whenever the sinusitis is prolonged, severe, or if there is double seconding, we think that this is a bacterial sinusitis. What is prolonged? If the patient is having symptoms which is more than 10 days, if the patient is having rhinorrhea, nasal block, and daytime cough, which are the symptoms of sinusitis, which is lasting for more than 10 days, then we think about a bacterial infection. If it is severe, that means purulent nasal or postnasal discharge, which is lasting for more than 3 days, and high fever. That tells us that this is a severe sinusitis. Here also we need to think that this is a bacterial infection. Another thing is double sickening. Double sickening means a child who had an upper respiratory infection who was apparently recovering from the viral respiratory infection and then again develops a fever and increase in the nasal discharge. Then we think about a secondary bacterial infection. So that is the double sickening. So if the person has any of these things, then we will need to start an antibiotic. And which antibiotic will depend upon the risk of resistance in that child. If there are these factors, that is age less than 2 years, young infant, daycare attendance, where the child will have contact with a lot of children who may be on antibiotics, then prior antibiotic use in the last month, prior hospitalization, comorbidities, and immunocompromise. If these are then we need to think that there is a chance of our patient having a resistant organism, and we need to start on initiate second-line antibiotic therapy. If these factors are not there, then we need to initiate only first-line antimicrobial therapy. And what is this first-line and second-line antimicrobial therapy for sinusitis? As we said earlier, these are the 3 organisms that produce a sinusitis: pneumococcus, H. influenza, and Moraxella catarrhalis. All these 3 organisms are usually sensitive to amoxicillin. Amoxicillin is sufficient for these organisms, unless the patient has any features of any risk factors for drug resistance. And the thing is that pneumococcus can acquire resistance by changing the penicillin binding protein site. So if the pneumococci are resistant to penicillin or amoxicillin, we can overcome this by increasing the dose of amoxicillin. But at the same time, we need to know that H. influenza and Moraxella catarrhalis both can produce beta-lactamase, and if these are resistant beta-lactamase producing organisms, then we can add on clavulanic acid to amoxicillin to overcome resistance. So which antibiotic and which dose that we are going to select will depend upon the chance of resistance. If the patient is not having any risk factors for drug resistance, we need to start amoxicillin in the normal dose only, that is 45 milligram per kg per day in 3 divided doses. That is sufficient for a child with no risk factors or risk factors for resistance. Suppose the patient is having risk factors for resistance, we can start on high dose amoxicillin, that is 80 to 90 milligram per kg per day, or we can even start on amoxiclavulanic acid with the higher dose of amoxicillin. And here also we need to give antibiotics for 10 days, 7 to 10 days. And another group of infection which may be due to viral or bacterial is acute otitis media. In acute otitis media also, a vast majority of them are actually due to viral infections. And here also whether we need to prescribe an antibiotic or not is depending on 3 factors. The first one is severity, second one is laterality, and third one is age. If the patient is having a severe infection, bilateral infection, or if the age is less than 2 years, that child should be started on antibiotics whenever you see the patient. But if the patient is having a mild infection, mild otitis media, which is unilateral, and it is in a child above 2 years, we need not start antibiotics when we see the patient. We can afford to wait for 48 hours because most of them are actually due to the viral infection only. So we can, whenever we see the patient with an otitis media, if it is a mild otitis media and unilateral in an older child, we can prescribe antipyretics, paracetamol, and also along with that we can prescribe antihistamines and nasal decongestants, and most of them will actually respond to that. And if the patient is not responding within 48 hours, then we can start an antibiotic. Here also, which antibiotics to start? It is similar to the sinusitis because the organism that produces acute otitis media is again pneumococcus, H. influenza, and moraxella. So the antibiotic selection is either amoxicillin or amoxicillin clavulanic acid, depending upon the chance of drug resistance in our child. We will move on to the next group of infection. This is a 3-year-old child with fever, cough, tachypnea, chest retractions, and on examination, child is having bilateral crepitation. So we will clinically make a diagnosis of pneumonia in this child. And when we look at the organisms that produce pneumonia, that will vary depending upon age group. The frequency of organisms producing infection will vary depending upon the age group. But in all age groups, across all age groups, the most common bacterial infection that produces pneumonia is still pneumococcus. And another thing that we need to do is in the age group between 3 months to 5 years, that is the usual age group where we usually see patients with respiratory infection, the viral infection is the most common one. And also we need to think about staph infection whenever the patient is having a severe pneumonia. And after the age of 5 years, the incidence of mycoplasma pneumonia infection also increases. It's not that you don't see mycoplasma infection less than 5 years, but after 5 years, you definitely have an increased incidence. It can occur even in smaller children. So whenever we select antibiotic for pneumonia, we need to give an antibiotic which is effective against pneumococcus. As we said earlier, pneumococcus is the most common cause for pneumonia in all age group. So we need to give an antibiotic which is effective against pneumococcus. So if the patient is not having any features of severe pneumonia, as evidenced by any danger signs, we usually start on oral antibiotics. And the usual dose of oral antibiotics, amoxicillin is the drug that we usually use. And the usual dose of amoxicillin for infections is 45 milligram per kg per day in 3 divided doses. 40 to 45 is sufficient. But the ARI control program recommends 80 milligram per kg per day in 2 divided doses. Why ARI control program is recommending higher dose is that this is for covering the penicillin resistant pneumococcus also. But another thing that we need to know is that if we're giving amoxicillin as a BD dose, the compliance increases. But if we want to give amoxicillin as a BD dose for pneumonia, we need to prescribe the high dose only for at least 80 milligram per kg per day should be prescribed. Because as we saw in the earlier classes, amoxicillin is a beta-lactam antibiotic, and the mechanism, the main factor which determines killing is actually the time above MIC. So 3 divided doses is always better than 2 divided doses, but we want to give it as 2 divided doses. It is better that you give at a higher dose so that you will achieve a higher concentration, so that the the period during which the level of the drug remains above MIC will be higher. So that is why if you want to give amoxicillin as a BD dose for pneumonia, always give 80 milligram per kg per day. Otherwise, if you are giving 3 times a day, if the patient is not having any risk factors for having a drug-resistant organism, the usual dose, even the usual dose is sufficient. And if the patient is not responding, we usually use the second-line antibiotic oral drugs, cefuroxime and co-amoxiclav. And in children above 5 years, we can add on macrolides or doxycycline along with amoxicillin to cover for the mycoplasma infection also. And if the patient is having features of severe pneumonia, significant respiratory distress, then chest retractions, saturation is less than 92%, danger signs, then these children will be admitted. And even for admitted patients, our first line antibiotics is still ampicillin only. That is in parenteral preparation, ampicillin only. And the dose of ampicillin we use is also high on the higher side, that is 50 milligram per kg per dose 6th hourly. That will come to 200 milligram per kg per dose. This is sufficient for most of the pneumonias. So in our patient, our patient was having some features of respiratory disease, patient was admitted and patient was started on IV ampicillin, and an X-ray was also taken, and this is the X-ray. And when the X-ray came, we can see that there is a pneumatocele-like lesion here. And so whenever patient is having, so we need to think about staphylococcal infection also. So if it is staphylococcal pneumonia, it is not going to improve with our amoxicillin or ampicillin. So we need to suspect staphylococcal pneumonia whenever the patient is having a rapid worsening of pneumonia. But a child with pneumonia was having some tachypnea and chest signs in the morning, and by evening child is having severe respiratory distress. That is a rapid worsening pneumonia. And any child with pneumonia who is critically ill, a child with pneumonia and septic shock, think about staphylococcal pneumonia. Whenever a child has any other focus of staphylococcal infection, such as abscess or pyoderma, an X-ray showing pneumatocele or pneumothorax, and pneumonia in an immunocompromised child could be staphylococcal pneumonia. Pneumonia following measles or viral respiratory infections, or the respiratory epithelium is shedded, then there is increased chance of getting staphylococcal pneumonia. And whenever the child is not improving with the usual antibiotics also, we need to think about staphylococcal pneumonia and give appropriate antibiotics. As discussed in the earlier classes, the selection of antibiotics for Staphylococcus was discussed in detail. I am actually not going into the details of selection of antibiotic for staph pneumonia. The first line antibiotic we usually use for staph pneumonia is only cloxicillin. And we will move on to the next case. This is a 2-year-old child with high fever, vomiting, suprapubic tenderness, and renal ankle tenderness. Urine microscopy shows plenty of pus cells. So this is a child with urinary tract infection, and from the history and examination, it is likely to be an upper urinary tract infection or pyelonephritis. So this is the next group of infection that we usually see. And whenever we see children with pyelonephritis or urinary tract infection, the most common organism that produces UTI is E. coli. It could be also be due to other gram-negative infections like Klebsiella, Proteus, Pseudomonas, Enterobacter, or other infections, organisms like Enterococci. But the thing is that in the normal urinary tract, without any obstructions, usually E. coli is the one which produces infection, and these other organisms usually produces infection in abnormal urinary tract, especially if there is an obstruction, calculi and all. We usually see the other organisms which produces the infection. That is not a hard and fast rule, but usually that is the one that we usually see. And when we select antibiotic also, we need to select antibiotic which is effective against E. coli. And whenever a patient is having high fever, systemic toxicity, renal ankle tenderness, or deranged RFT, that child is said to have complicated UTI. It indicates that the child is having pyelonephritis. So, whether to give oral antibiotics or IV antibiotics will depend upon the clinical features. If the child has complicated UTI, as evidenced by the high fever, then renal ankle tenderness, and clinical urosepsis, then that child will require parenteral antibiotics. And in any infant less than 2 months, we always give parenteral antibiotics for UTI. And then other indications for parenteral antibiotics is immunocompromised patient and also inability to tolerate oral medications or not responding to oral medications. So other than that, for all UTI, we can treat with oral antibiotics. So if there is features of pyelonephritis or in small infants or immunocompromised only, we usually start on parenteral antibiotics. And the parenteral antibiotics that we usually give is third generation cephalosporin. We will give cefotaxime is the usual drug that we give for urinary tract infection, and we will modify this according to the urine culture and sensitivity. We always need to send a urine culture and sensitivity before we start an antibiotic, and when the urine culture comes, we will modify antibiotics accordingly. If that is Pseudomonas, we may have to give aminoglycosides. Other than that, usually cefotaxime is sensitive for E. coli unless it is a drug-resistant infection. And the duration is, if it is a complicated UTI, we may have to give antibiotics for 7 to 14 days. But if it is a uncomplicated lower urinary tract infection, we can do shorter duration of antibiotics. And oral antibiotics in UTI, here, this is the only conditions where we prescribe a third generation cephalosporin as a first-line drug in an OPE settings. We prescribe cefixime because it is a gram-negative, as we said earlier, the most common organism is E. coli, which is a gram-negative infection. So we need to prescribe a third generation cephalosporin. So cefixime is effective in almost all cases of urinary tract infection. And if it is Pseudomonas, cefixime is not effective, then we may have to give fluoroquinolones. Co-amoxiclav is another one, Augment is another one which we can use, and Septrin is can also be used in UTI. And here also, depending upon the culture results, we may have to modify. And nitrofurantoin is the one antibiotic which is recommended in adults for almost all. There is a level 1 recommendation is for nitrofurantoin, but this is nitrofurantoin is not effective for pyelonephritis because it does not achieve any significant renal tissue levels. And in children, there is high chance of developing pyelonephritis also because the children will have a less deficient immune system and they won't be able to actually limit the infection to the urinary and lower urinary tract in case of small kids. So young infants, there is high chance of pyelonephritis. So usually nitrofurantoin is not useful in the children. Here we prescribe, we usually use the third generation cephalosporin as the first line drug. If it is an oral drug, we use cefixime, and if it is an IV, we use cefotaxime. And we will move on to the next case. This is a 6-month-old baby who is brought with fever, loose stools, no blood in stools, and examined some features of dehydration. Should we start an antibiotic for this patient? This patient is actually having an acute watery diarrhea. And the most common cause of acute watery diarrhea is viral infection, that is rotaviral infection. There is no need for starting antibiotic for a rotaviral infection or any viral infection. So there are definite indications for starting antibiotics in acute diarrheal disease. That includes, the first one is acute invasive diarrhea, or you have visible blood in stools. It is not that by doing a stool microscopy we are finding RBCs. Acute invasive diarrhea in children is evidenced by presence of visible blood and mucus in the stool. So if there is visible blood in stools, we can start on antibiotics. If we suspect cholera, as in an older child coming with severe dehydration, rice water type of stools, persistent vomiting, we may suspect cholera. Especially if there is occurrence of cholera in the nearby houses, we need to suspect cholera. Then another thing, these are the two definite indications where we give antibiotics just due to the diarrhea. And other indications are whenever there is a child is having a malnutrition, severe malnutrition with diarrhea, we will need to give antibiotics because there is high chance of a sepsis. And in less than 2 months also, here also the child is actually, we will not be labeling them as acute watery diarrhea. Here also diarrhea is also actually a part of the sepsis only. And if the child is having any coexisting infection also, we will start on antibiotics. Just because the child is having some fever, in the case of acute watery diarrhea, we need not start on antibiotics. And which is the antibiotic that we use for acute invasive diarrhea? That depends upon the guidelines. The WHO guideline states that advises ciprofloxacin as the first-line drug for acute invasive diarrhea. But they also tell us that we can modify antibiotics depending upon the local resistance pattern. Here we have a higher incidence of nalidic acid resistance. So ciprofloxacin is not used as the first-line antibiotic for acute invasive diarrhea here. Here we use third generation cephalosporin, that is oral cefixime is used as the first-line antibiotic. And if it is a resistant Shigella, we can, if the patient is not very sick, we can change over to oral azithromycin. Okay, so antibiotics, these are till now we were talking about conditions where antibiotics were indicated. But at the same time, we need to identify that for these acute infections, antibiotics are not at all indicated. For acute diarrheal disease, viral upper respiratory infections and other viral fevers such as dengue fever, chikungunya, hand, foot, mouth disease, all these viral fevers are very common in children. So in those conditions, antibiotics are not indicated, and we should never prescribe any just in case antibiotics. Sometimes parents may demand that even though we are telling them that this child is now having only a viral infection, they will demand that the doctor just prescribe an antibiotic, and if the fever is persisting for 3-4 days, I will start antibiotic. Never prescribe just in case antibiotics. We need to teach them. We need to tell them that the patient does not require an antibiotic, and we also need to tell them the adverse effects of antibiotic and what will happen if we give antibiotic unnecessarily. For this, we can keep these types of posters, especially in the waiting room before the patient enters into the doctor's room. If we can show these types of posters, then it will actually help in our health education. Okay, that completed our source. Then we will say, then the selection of antibiotic will depend upon the chance of our patient having a resistant organism, harboring a resistant organism. For that, we can actually divide the patient into different groups depending upon the contact with the healthcare system and antibiotic use and presence of comorbid conditions. A type 1 patient is a patient who does not have any contact with the healthcare system, no antibiotic use in the last 90 days, and no comorbid conditions. This patient is very unlikely to have any resistant organism. If he gets an infection, it is usually due to the organisms which are sensitive to the first-line antibiotics. And type 2 patient will have some contact with the healthcare system, may undergo minimally invasive procedure, and may have received antibiotics in the last 90 days and may have few comorbid conditions. This is the typical healthcare associated infection. So this patient actually may have a drug resistant organism, especially there is chance of MRSA and some ESBL. But other non-fermenters and bronchial infections are very unlikely in these children. These are the two types of patients that we usually see in the outpatients when we from the community. And the other types, type 3 is actually a hospital acquired infection, and type 4 is a hospital acquired infection who's not responding to the antibiotic. These two types of infection we don't see in the outpatient practices, and actually not going into the type 3 and type 4. So if, as I said earlier, in the type 1, we usually the patient will be having a bacterial infection, and there is no very minimal risk of having a MDR pathogen. And if it is a type 2, there may be a chance of MRSA and ESBL producing organism, but the other organisms are rare. In type 3 and type 4, we have high risk for non-fermentase, and in type 4, even invasive fungal infection. So we will decide which antibiotic to use depending upon whether our patient belongs to the type 1 or type 2. If it is type 1, as we said earlier, we need to give only the narrower spectrum antibiotic for that. And also we need to consider the WHO aware classification and try to give antibiotics from the access group only in the outpatient settings. And in the inpatient settings also, we need to limit our antibiotics to the access group and wash group, and reserve our antibiotic in the reserve group. And reserve group antibiotics should be given only when it is definitely indicated, especially linezolid, which is available as an oral preparation, is the one reserve drug which is misused. And the next factor which will determine the choice of antibiotics is patient factors. Here, sometimes our patient may be having a renal problem. Then we may not be able to give antibiotics such as aminoglycoside for that patient. And also the next one is culture. Depending upon the culture and sensitivity, we may need to modify our antibiotics. That completes the selection of antibiotics. Then we all know this gentleman. This is Dr. Simelby's, he was the one who first discussed about the importance of hand washing and said that puerperal sepsis can be prevented by hand washing. He was the one who propagated this, and the only method by which we can prevent infection in the early stages was by infection preventive practices. And as we are having an increase in the resistance, what will happen is that in the coming ages, we will have another phase where also we will have the only effective measure of this infection will become the infection preventive practices, unless we practice the antibiotic stewardship very properly. And we were saying in the previous days about the front-end approach and back-end approach in restriction of antibiotic stewardship policies. But in the most of the hospitals, only one or two physicians will be there. So it's not that we should not think that an antibiotic stewardship team will come and tell us about the antibiotic stewardship, or they will modify. We actually need to be self-stewards. So whenever we are prescribing an antibiotic, we need to think twice whether this antibiotic is needed. And also, if the antibiotic is needed, we need to make sure that this is the right drug which is needed for that condition, and we are prescribing the drug in the right dose and duration. Thank you.